So, Professor Denny, if you are ready, then we can start the session. People will join.
Yeah, I'm ready. Thank you. So, any queries or any questions from yesterday's session? Today we are going to focus how to develop protocol. Any question? Yeah, go ahead. Somebody raise your hand, you can go ahead, please.
Hello.
Yeah.
Sir, I joined the class today itself. I actually didn't see the alerts. So is it a problem? Can I get the recording, sir?
Yes, you will get the recording. You just observe what is happening today.
Okay, sir.
It will be since you have enrolled for the systematic review meta-analysis course, and today's
Sir.
session is related to protocol development. So I thought you should attend today to have
Okay.
a brief idea.
Okay, sir. Thank you.
Anybody else has any other question? Okay. So I think yesterday we tried. So I gave yesterday, if you understand, I had given two examples. Do people remember which are the two ways in which systematic review of economic evidence is conducted? Do you remember from yesterday? When do we apply like two types? Does anybody remember? I've forgotten. Yeah? We discussed yesterday that you will be, we do systematic review of economic evidence for two components. One is identifying economic burden of a disease. And the second one is where you want to look at a cost effectiveness or a cost benefit or cost minimization between two interventions. So these are the two applications where you look at economic evidence. If I were not clear yesterday, I would suggest people to speak up and make it a little interactive. It gets a little boring for the faculty to keep on talking and not getting any response. I don't enjoy that. Do people are able to listen to me what I'm saying, or because nobody's responding?
we
so I'm
can
trying to. Yeah. So yesterday I mentioned to you that there are two, applications where you look at economic evidence, and one of the things that I also mentioned is when do you see where basically we are saying that the economic evidence is looked into when you want to look at economic outcomes. And the second one is where you try to look at the cost effectiveness of a particular intervention. Okay. So I'll make you go through to both. If you can, do you all see my screen?
Yes, sir.
Okay. So this is so I'll give you two examples. One is focused on, I think this is let me take this as because this is standalone. This is the combination. Do you all see the protocol for neonatal systemic infections in South Asia? Do you all see this? Can you see the screen?
Yes, sir.
Okay. So this is an example. I'll send you the link in the chat box so that you have a background. Yeah. So this was done along with my PhD student. Shruti was my PhD. I was a co-guide. She's completed a PhD, I think, last year. So she was focusing on neonatal systemic infections, and we felt we should do a economic evaluation as part of her PhD for the cost effectiveness. So I'm just going to go through this so that all of you understand, because this is, I do not know if you notice, where is the number of, yeah. So many people have cited this, but also accessed. And I'll just explain what is it so that you understand. So whenever we are looking at a protocol, one of the things that we have to do is we have to ensure what are the operational definitions of that disease. Okay, and you'll also notice that there is a PRISMA guideline that is only for the flow chart, but there are also methods around Cochrane collaborations, it's really CCMG guidelines, and the National Institute for Health and Care Excellence, NICE. So the reason that we use multiple guidelines is because PRISMA is only identifying the screening and decisions for included studies, but the way that a protocol for economic evaluation has been to be conducted, as I explained yesterday, the chapter 20 of the Cochrane handbook. But there is an organization called NICE. They have their intent. The NICE is the HTA body or a decision body for UK, and they have a lot of guidelines because they use HTA as one of the principles for, or as one of the methods for making policy decision. And as part of an HTA review, they expect that the drug manufacturers or medical devices, or these days digital health, all incorporate economic evidence systematic review to justify where does the new intervention that they are proposing to be introduced in the UK should be, where does the previous evidence stand. So one of the things that we always have to remember is that, and this is something that I follow across all, but this is also important for economic evaluation majorly, so that people understand what kind of economic evaluations are you considering, but also the definitions of this. So I usually use one paragraph called as operational definition, and I use neonatal disease so that is clear. If there is a context, then I use that also so that I justify how am I using, because please understand that there is South Asian is SARC. That is one level. Some people say, no, I want to look at all South Asian, WHO, CRO region, the South Asian countries. So in case you need a different, approach to look at any country, you need to justify. Typically, we use World Bank. So World Bank is used for income, high income countries, low income countries, lower and middle income countries. But if you're suggesting a geography, figure out some kind of reference to justify. For example, if you're doing a systematic review focused on Asia Pacific region, so you need to list down which are the countries that you're looking at. Then we are also mentioning, you have to also mention, are you considering both full and partial economic evaluation? And the way that we define is the CCMG the chapter 20 defines full and partial economic evaluation. So, for example, cost analysis. These are considerations in partial economic evaluation, and cost effectiveness, cost utility, cost benefit, cost minimization, and cost consequence becomes part of full economic evaluation. So you have to ensure and clearly say, and this is what I said, that for economic evaluations where you're looking at economic evidence of a particular disease, you have to include both kind of economic evaluation. The reason being that full economic evaluation, you're not trying to understand whether one intervention is effective or the other. Since these methods have cost in the numerator, that will be evidence for us as part of the economic evidence. So please do not consider only cost papers or cost analysis papers. This is a question that many people ask. Currently, as I said, I'm advising WHO SCRO for economic burden of NCDs in South Asian region. And this is the same thing that, when we were initially discussing, I said, no, you have to include cost effectiveness or cost utility, because there is cost reported in those as numerator. So please do not, when you're looking at economic burden or economic evidence around a particular disease, ensure that you're looking at both full and partial economic evaluation. So any method that that reports cost should be considered when you're looking at burden of disease, economic burden of disease kind of approach. Second is inclusion criteria. When you're looking at inclusion criteria, you have to define, as I said, you'll have cost analysis, cost outcome, cost description, and cost of illness. This becomes part of full partial economic evaluation, and then you have cost effectiveness, cost benefit, cost utility, and cost minimization. Typically, even if you ignore cost consequence, that's fine. There is very extremely low number which is going to do a cost consequence, so you can ignore them. And then you need to also say that what would be the exclusion criteria, because in this case, we were not interested to look at any kind of neonatal systemic infection that is secondary to a disease or a condition. For example, surgery. We were also not interested to look at studies which are exclusively reporting only quality of life, patient-reported outcomes, and utilities without the cost. And like any other systematic review, any kind of reviews, editorials, commentaries, or methodological articles will be excluded. However, you have to include a look at the bibliography of systematic reviews so that we can see if any relevant studies have to be let into for inclusion. But these reviews are not eligible for inclusion. So here, the type of population will be neonates diagnosed with one or more systemic infections from any of the specified South Asian region. Here, it is independent of any intervention. It's related only to infection management. So it is independent within that. So it could be medical devices, it could be guidelines. So irrespective of the study settings, which is primary, secondary, tertiary, and community, and comparison can either be a placebo, which is a passive comparator, or an alternative standard of care, which is an active comparator, or you can also have a do-nothing scenario, which is again a passive comparator. So these are the kind of studies that we come in. The important factor is what are the type of outcome measures. And this relates to resource use, cost, and cost effectiveness. So here I'm going to just explain. Remember that there is something called as measures of resource use. So you have medical, which is all direct cost. See, remember the difference between resource use and cost is basically saying that resource use is basically the number of units or resources used. So for example, number of outpatients, consultation, and these resources used might not be reporting using cost. These are called as resource utilization studies. So any kind of resource utilization is also need to be considered. Just don't assume that wherever only cost is reported, it become economic. Even if resources get utilized, those also should be included in an economic systematic review of economic evidence. So resources would mean probably outpatients, hospitalizations, provider services, any kind of drugs, supplies, devices, medical assistive equipment, investigation, and procedures. It could also be non-medical, for example, overheads, equipment, transportation, travel, waiting time, etc. And then you have indirect, which is number of work days lost or by the guardian as a result of the neonate's illness. If you're taking cost will be reported in terms of cost estimates per specific resource item. So you're saying that if studies report cost of OPD, you will report that. If they're saying cost of IP hospitalization, you have to report that. You have to also report the level of cost, which is basically you're saying that is the cost at the primary care level or the secondary care level or the tertiary care level or even at the household level, and what is the category of cost. Will it be, you will categorize them into direct medical, direct non-medical, indirect, and then also total. So that is where you try to look at average cost. And when I'm saying average means you have to take the mean cost with any kind of 95% CI or standard deviation, standard error, sorry. And in case you need, you have expenditures, sometimes expenditures are reported in interquartile range. Sorry, so you need to keep that in mind also whenever you're looking at. So some studies would report average, some studies would report median. So if median is reported, IQ or interquartile range also have to be taken into consideration. When you're looking at measures of cost effectiveness, as I explained yesterday, that the outcomes will be in the form of ICER, which is incremental cost effectiveness ratio, incremental cost per quality adjusted life year, incremental cost per disability adjusted life year, incremental cost benefit ratio, and net cost. So these are the measures of cost effectiveness. And then, the paper also gives some additional supplementary in terms of outcomes. Let us see what did we do it. It's a little dated, so I do not remember everything. Where is it? So these are the detailed, outcomes that we gave as a table. If you all can see my screen, uh, and this is, you can use this for your own any planned systematic review, just copy paste it. It doesn't change. It doesn't matter which disease are you looking at. All these things will remain constant. So direct medical will relate to all the healthcare utilized for the management of the disease. However, you have to ensure that all the resources are relevant to the disease condition. Direct non-medical could relate to services, transportation, meals, accommodation, relocation, and moving, but also informal care, for example, travel and waiting time. And then indirect would be number of hours or days of work lost as a result of the neonate's illness. When you're looking at cost items, these are the specific cost items: cost of hospital stay, cost of outpatient visit, cost of consultation, meals, informal care, ventilator, imaging, wages, productivity loss, transport, cost of relocation, for example, or cost of provided services, which could be specialist, physician, nursing, housekeeping. This is the direct medical, direct non-medical, and indirect cost level is either average, average total direct, and average total direct non-medical cost. Any idea what is this average total direct medical cost? Either people must be used to either average or total. What is this average total? Any idea? Anybody? People understand average cost, but that also I have to explain. If you want me to explain, I can explain. Vijay, I think we should not keep Sunday as the class. Everybody is silent today. Any idea what is the average cost logic? Why do we say the average cost?
It is the total direct and indirect cost of
No, that is total. But what
that.
is the concept of average cost? Average. How does this average come? In cost, we are considering only two components. One is average or mean cost or median. But most costs will be reported in mean. When you're looking at expenditure, most studies will report median. Any idea what is the difference between both? These are basic stats. But what is this concept of average in cost? How does this average come? Only then I'll be able to explain what is average total. So the average, the logic that why we use average is because let's say I have mean cost of one patient, cost of second patient, cost of third patient, cost of fourth patient. The average cost is because the sum of these costs divided by the number of patients. So the total cost is divided by the number of patients, and that is why all costs in health economics are reported. Economic evaluation are reported using average costs. Because it is say patient 1, patient 2, patient 3, patient 4. We take the cost for each of them. So then the sum, that total divided by number of patients, that is why we have the concept of average cost. Then what is total average cost? The same logic applies. For direct cost, you'll have an average, total average. You'll have a total average because you'll have average cost of consultation, average cost of hospitalization, average cost of say probably any kind of medications if it's separate. So this is average, this is average, this is also average. That is why this is a total average. That is the concept of total average in economic evidence. So you have to extract data for both direct, all of these individual average, but also total average, but also include medical, non-medical, and indirect. So I'll just stop here in case people have not understood. In that case, I can repeat it. People understood the concept of this average and why we call it total average. People have clear with this?
Kindly repeat once.
Which one? The entire thing or which one? Have you understood average cost? Or that also not clear.
No.
So you come from a medical background?
Yes.
Which specialty, if I may ask?
I am in transfusion.
Okay. So let's say that you have the logic, the way that we calculate cost in a cost analysis is we take a sample of patients, right? So essentially you mean that patient 1 ka liya, patient 2 ka liya, patient 3 ka liya, patient 4 ka liya. And then you're taking their direct medical, non-medical, right? If you're doing a prospective study. If you're doing a retrospective, non-medical and indirect, it's not possible. Because the case record will only give you uska purana bill. So it will not give you. So this is total cost that patient 1 has paid. So let's say 100 rupees. Patient 2 has paid, let's say 90 rupees. Patient 3 has paid, let's say 80 rupees. Patient 4 has paid, let's say 50 rupees. So what is the total?
320.
320. 320 is the total cost paid by 4 patients, but this is not this will not give us a proper answer because just by putting 320 will not make sense. So,
So
320 divided
may I
by 4 will be 80 rupees. Sorry, 80 rupees. So that is the concept of average cost. Is that now clear?
Yes.
So जब ये 80 है, this is only one type of cost, right? Let's assume that direct medical है. Direct non-medical में same thing. Patient 1, 2, 3, 4, 5. In that case, you will have something, let's say another averaging, you get another 20. Then you have indirect में और एक 30. So ये average है, ये भी average है और ये भी average है. So the total average is 80 plus 20 plus 30. So 130 rupees becomes total average. That is the concept of total average. Is it now clear?
Yes, sir.
So papers report only direct. It will not tell you direct medical, and that is another why I explained the concepts on that day was to understand that the main problem with economic evidence is economic studies is they will not report my direct medical, direct non-medical, and indirect, or any kind of cost categories or cost level, or any kind of the cost effectiveness will report this, so it's very straightforward. But if you do not understand the concepts, you do not know under which data extraction category should I group them, and how do I report them when I'm doing a synthesis. That is the reason I went with some basic theory. And as long as you take this sheet, this will not change. But only specific to certain disease. So maybe if you are looking at something else, then you might have some additional cost component that might be relevant to that. For example, stroke. Then you're also looking at physiotherapy or something like that, or you're looking at spinal disorder. So those are, or probably if you're looking at something like severe depression. In that case, you don't have any, you might have maybe mental illness, might have some hospitalization, maybe not most hospitalization, but you'll have repeated outpatient visits. And then in that case, you might have two levels, one with the psychiatrist and another probably with the psychologist, depending on how that person is moving towards the entire management of treatment. So you need to keep in mind this concepts because this paper will not say direct medical, direct non-medical, or indirect. They will just report this cost or some resources that are getting utilized. Right?
so
Any question?
to make it more interactive, so can you take one example, say for example average cost, because since it is a review and on a primary study where how the data is presented there and how they will extract.
Okay, so let me take my own example. I'll just see whether I have a paper.
Or is this protocol, the main paper is published for this protocol or not yet?
No, the final review is not published. This is
Okay.
just the protocol. But you wanted a primary study, right?
Yes, one take, just we have another 3-4 sessions. So take one primary study and let us focus on one outcome, say average cost.
Yeah, let me see if my full paper is available.
Send the link. I will send. Just post the link in the chat. I will give the full paper.
No, full paper, unfortunately, in for Indian Journal of Tuberculosis is not willing to share. Give me 1 minute. I have.
No,
I
I
cannot.
can extract the full paper from my library. Just post the link in the chat. Hyperlink.
Yeah, because I'm from my own paper, it will be easy how I calculated. That's it.
So, that paper only. Just give the hyperlink. I will get the.
I've sent it on chat box.
Okay.
There are 2 papers. I think those are sufficient. I have more, but for the timing, this.
So first try at your end. I am trying.
I have the full paper, but I need some time. I need to pull it up.
So it is 2017 and 18 paper, but it is not access.
Give me
PJ
one-
doesn't have subscribed to this paper.
Yeah, no problem. I have the full paper.
Anyone can
Okay, one.
paper?
Yeah, no, I have the paper with me. I just had needed some time.
So friends, please
You know,
focus. This is most important lesson takeaway. How you find the data? Because since this is a review, you do not calculate the average cost. That is for the primary studies role.
can all of you see my screen?
Yes, sir.
Yes.
Yeah, so this is a model that I developed. We wanted to check. We wanted to understand what is decentralized care for managing MDR-TB cost effective in the context of India. So this is an old paper, 2018, so it's a little dated, but I think it will give you an idea of how cost. So this is a cost effectiveness paper. However, you'll notice that why cost effectiveness, why economic study. If you're looking at cost effectiveness, then you also need to check. Typically, you might end up looking at a cost effectiveness using some kind of a model. So in this case, we used a decision tree model. In some other papers, you'll notice that there is a Markov model, and then the third method is called a patient level simulation. So these are the three modeling methods that you will have to consider, and that is something in that I'll explain in detail when we do the data extraction in the next class. But essentially, there are three methods for modeling, and the other one to do cost effectiveness is where you do cost effectiveness alongside a clinical trial. So that is also another way to measure cost effectiveness as part of. So if you notice here, this is how the cost is reported. Do you see all the cost inputs that has got? Do you see this table too?
Yes.
So typically, this is how we report cost inputs for the model. So here in this case, since there are two interventions, centralized care versus decentralized care, we also use the data source now. And this is something that my team currently, who's doing the systematic review of economic evidence, is should I take this reference or should I take this paper's reference? The problem is this paper will not report this directly, yeah? And this is something of a challenge because some papers, when we're looking at cost, we calculate it for a certain number of population because the model will have some hypothetical population. And that is where I said that for some economic evidence, when you're looking at cost effectiveness, it's good to have a health economist because then he can tell you how the cost is reported. Is it per unit cost or is it, calculated across a certain population? Because in cost effectiveness, you're actually modeling it over a period. In this case, our time horizon was only 12 months, but let me just show you another paper so that we have an idea of the difference because anybody who's an ophthalmologist in the group? Any ophthalmologist? So this is a cost effectiveness that I've done, which is in a disease condition called macular edema associated with uveitis. And this was part of an international team. This is not done in India because I was part of the consulting group, which was doing it for a pharma company based in the US. So this is focused on United States. It's not done for India. And you'll notice that there is a patient level simulation that was done. So this is another method where we do modeling, patient level simulation. And in this case, there are costs that are reported in terms of various structures like wholesale acquisition cost. Wholesale acquisition cost is basically the cost at which this entire, wholesale cost of this triamcinolone acetonide is available provided to the hospital. And then we also have to look at suprachoroidal injection because that is an additional cost over and above the drug cost. So this is two ways in which, as I said, that it could be a decision tree, it could be a patient level simulation. In case you're looking at cost effectiveness kind of a systematic review, then you also have to extract data in terms of the modeling method. And I'll explain during the data extraction stage what is to be considered. But let's go back to understanding the cost. So you have total therapy drug cost at clinic, bed charges, 7-day admission, because that is what we have assumed that this is 7 days for all and come from a primary study. What is the bed charges? What is the health worker cost for injections? Then food in town, visits to laboratory and MDR center, and then the overall cost with 2014-15 figures. Because please remember, this is the 2018 paper, so we had only this one, and then we converted that. So given this, any idea which will be coming into direct medical, which will come into direct non-medical or and indirect? So what will go? This is the cost table. अभी इसमें अपने को, can you tell me which will go into direct medical, which will go into indirect, and what will go into direct non-medical? All of you can see the paper, right?
So visits would go into direct and medical, indirect. Sorry,
Visits to laboratory will go to
indirect medical.
no. If you were, did you attend yesterday's class? If not,
Yeah.
because the indirect is only the productivity loss component, right? Visit to laboratory or MDR center would be a direct medical cost, because the logic of always remember this this particular logic. This is not there in any textbook. Any cost that is incurred to manage the disease is direct medical cost. Now, management of the disease would mean I need to spend on laboratory to diagnose the disease. I need to spend on consultation to again diagnose the disease based on the laboratory diagnosis, laboratory findings. Then you also need medications. You might need surgery. So any costs that are incurred to manage the disease directly becomes direct medical cost. Any costs that are borne for receiving the direct treatment will be indirect, non-medical. So if you do not travel, you are not going to receive care. That is why travel is direct non-medical. If you have a relative, that food expenses of that relative will be direct non-medical. And indirect is simply loss of wages or productivity losses. So I'm asking again, this is centralized care. Always keep the disease in mind also. Don't randomly put it into some category. So can some people say which will be the direct medical, direct non-medical, and indirect based on this? Because this is where the logic comes. We do not have this concept. Just reporting this cost will not make sense. So which will be the direct medical, which will be the direct non-medical, and which will be the indirect?
Direct non-medical will be total therapy. Direct medical will be total therapy drug cost, cost at clinic, then pre-treatment and post-treatment testing. Admission will also come in direct medical cost.
Okay, admission then. Sorry, please go ahead.
Okay, bed charges, doctor consultation fee, and ancillary drugs for 6 months. They'll also come in direct medical cost. Health worker cost for injections, it'll be, since it is disease related only, for management of the disease, it'll be again a direct cost, direct medical cost. Food in town will be direct non-medical cost, and visit to laboratory and MDR center will again be direct non-medical cost.
Exactly. So this is where in the data extraction, you will have two rows whenever you're doing an economic evaluation or an economic evidence systematic review. Your first row will be the direct medical and the various categories that you're saying and then you have to put it there into outpatient and drug. But you'll know more detail on this. But this is how cost is reported in a cost effectiveness paper. Okay.
Excuse me, sir.
Yeah.
Sir, visit to laboratory and the MDR centers. Sir, how can it be direct non-medical? Sir, it should be direct medical.
Basically, this is 12 visits to a diagnostic laboratory. So it is basically the laboratory, MDR center ka jo, let me just see whether it is travel or
Sir, it is the
मेरे को भी
diagnosing
एक
the
मिनट
cases or
एक मिनट मेरे को ये देखना है कि ये लेबोरेटरी का कॉस्ट है या ट्रैवल का कॉस्ट है। एक मिनट sorry, so this is a non-medical because this is a travel cost, this is not a direct cost, no? So visit to laboratory is a non-medical cost, direct non-medical, and food in town is also non-medical. So these two are non-medical, all of these are direct medical. I think that is why it is written below this. So this is not a medical cost, my mistake. This is a direct non-medical because this is the cost of travel every time that you're going to a diagnostic laboratory and also to the DRTB center. So ये travel cost है. So all the first component, which is still health workers cost of injections, will be direct medical, food in town, and visit to laboratory and MDR center is direct non-medical. I'll give you another example because this has got an intervention. I mean, it's a treatment, but let's say if you have an intervention, then it becomes little complicated. So let me give 1 minute. Vijay, you don't have the glaucoma screening paper also? I've
No,
sent you 2 links.
no, I didn't get that.
Okay, that also is not possible. So give me 1 minute, I'll pull it out from my database.
So economic evidence is very good area. If somebody wanted to make a career here, please try to understand the concept because there are hardly very few people in our country doing this, and those who are doing, they have a good name.
So this is another paper in case you want to know how to, can you all see my screen with the cost effectiveness and cost utility of community screening for glaucoma in urban India?
Yes,
All
sir.
of you can see my screen? Yeah.
Yes, sir.
So this was actually a little delayed, but this was part of my MPH thesis when I did my second master's, focusing on health economics. I was actually trained in University of Auckland in New Zealand using a Commonwealth scholarship. So let me see whether the cost is calculated. This doesn't have so much detail. There were 2 papers. Yeah. Can all of you see my screen?
Yes, sir. Yes, sir.
We had actually done two papers because when we looked at the glaucoma prevalence, we found that the rural and urban prevalence is different, but also the costs were different. So we split the same paper into two papers, one focusing on urban and other one focusing on rural. So this is a screening. So you have cost of the entire screening clinic, but also the cost of the treatment of the disease as well. So, for example, you have examination, medical, surgical treatment, and then you have all of these costs, which are basically calculated using a certain number of population. Social marketing cost. This is pre-screening. That means you have to incur some cost for inviting people to a glaucoma screening program in the community. So that has been calculated at the rate of 1,000 per 1,000 population. कि per 1,000 को बुलाना है तो कितना खर्चा होता है. Then what is the screening invitation cost per person? Then average rental value of capital equipment, because we wanted to cost the program. So जो rental value है capital equipment में जिसमें instruments है, then other equipment, annual salary, stationery, तो ये transportation, तो ये जो पूरा cost है, finally जो आता है 297, which is the screening clinic cost per person. And this is the type of cost which are incurring in terms of the examination. These are all medical direct costs only. We have not captured any non-medical or any kind of the indirect. It's purely medical expense. So in this case, how will you categorize them? ये जो social marketing screening है, ये direct medical तो सिर्फ तीन ही है, तो ये कहाँ जाएगा? Screening cost और ये सब कहाँ जाएगा? Any idea? And you'll notice this in a lot of these, if you're focusing on screening, if you're focusing on immunization, because you always have cost of, social marketing for getting the people to come for immunization. And then there is a cost for immunization. So if you're looking at where you are inviting people, screening, immunization, these kind of aspects, you'll have multiple costs. One would be to get the people to receive that intervention. It could be, for example, anemia intervention also. Micronutrient program है. लोगों को एक आंगनवाड़ी में या कोई सेंटर में बुलाना है और वहाँ पे आपको माइक्रोन्यूट्रिएंट डिस्ट्रीब्यूट करना है. Then in that case, you have to consider the social marketing cost also. Now my question is, where will you categorize it?
So it will be a part direct non-medical.
No, madam.
Indirect non-medical.
No, indirect nahi hai na sir. Ye direct is only to manage the disease. None of these categories, all the screening ka jo bhi hai na, it has not got anything to do with the management of the disease. It's only to invite people to get the examination. So only these examination, medical, which is primary open-angle glaucoma, and then medical treatment for some patients which have got primary angle closure and primary angle closure glaucoma, and then finally you have surgical treatment because the very less patients actually get POAG. So in that case, we have calculated, and then there is one eye, some eyes, both eyes. So my question to all of you is, ये जो pre-examination है, जिसमें actually screening होता है, वो कौन से category में डालेंगे? Direct medical, direct non-medical या indirect? Or you think that no, ये तीनों में तो fit नहीं होता, कोई दूसरा category होना चाहिए? तो अगर वो दूसरा category है तो कौन सा category?
Operational cost.
हाँ?
Operational cost.
Operational cost. Okay. Anybody else has any other alternate suggestion?
Direct medical only, sir.
No, direct medical नहीं आएगा sir. when कोई लोगों को सिर्फ बुलाया है. And the other thing is, everybody who's invited and screened will not require examination also. Like सारे examination की जरूरत नहीं है ना, because एक algorithm बनाया हमने. Algorithm ये है. Actually अलग-अलग paper में अलग-अलग component. एल्गोरिदम यहाँ पे है, ये हमने एल्गोरिदम यूज किया था कि पहले रजिस्ट्रेशन होगा, देन पेशेंट का विजुअल एक्विटी एसेस किया जाएगा, देन रिफ्रैक्शन, पेरिफेरल एसीडी, आईओपी असेसमेंट, ऑप्टिक डिस्क and visual field examination. And then if they do not have any evidence of glaucoma, they'll be discharged home and then sent it off. And in case they need some management, then they'll be managed. So ये जो examination cost है, ये सिर्फ ये diagnostic test का ही है. उसके बाद ये जो ये जो examination ये सारे hospital related है. Clinic cost है ये screening clinic cost है. तो ये algorithm से आ रहा है. So it will not be called what is the category. It is definitely not part of by direct medical or non-medical, because you have to differentiate that is not the management of the disease, only for screening, only to identifying whether patients have the disease, and many patients will not have the disease for example. So कौन से category में डालेंगे? The category that will put it is called program intervention cost. So because this is a program and you want to differentiate between the program intervention which is happening in the community, and you also want to differentiate between the actual expenses that are incurred when the patient is in the hospital for further diagnostic tests and or surgery or medical. So when you're looking at public health interventions, specifically vaccines and also screening, you will incur certain expenses in the community, which is just to get the people to the whole. It could be done for public nutrition programs. I did one model for Sri Lanka where we looked at dengue vaccination. So उसमें भी हम लोग को we have to invite people to come. Otherwise, how will they know that there is a dengue vaccination going on in the community? So in this case, you will have to look at program intervention cost as a separate category. So it will not be either direct medical or non-medical or indirect. Remember, direct medical is only for the direct management of the disease. All those who are screened might not have glaucoma. Some might be just, there will be nothing. Some might be glaucoma suspect. All the glaucoma suspects will have to be sent to the hospital for further examination, because in this case, what we had assumed was that this screening is done by ophthalmic assistants. It was not done by an ophthalmologist. So for the actual assessment, you need to send the patient to the hospital, right? So in this case, the program intervention will be the cost of this. All these will be program intervention costs, and this will be direct medical cost. So some papers will use the word called unit cost. Some paper will use average cost. Some papers will use median cost also is possible. So please keep all this in mind. You might have this variations also. The chat has the reference to the full paper. But I'll just stop here in case there are any questions. I can go on and on. I have multiple papers. A lot of different methods are possible. This is cost effectiveness. Give me a minute. I'll explain what is the cost of illness so that you guys are familiar with that. I did one for dengue in Surat. Everybody can see my screen? All of you can see my screen.
Yes, sir.
Yes, sir.
Yes, sir.
So this is an example of what's called as a cost of illness. This is a cost of illness. We estimated what is the cost of illness for dengue hospitalization in private and public hospitals. And we used only what is called as a resource utilization. That means we used the medical records to identify all the resources which are spent, and then there we took the cost. So all the methods of what are all the costs that we actually looked into. So for example, the direct medical cost included room charges, lab, doctor rounds and consultation, nursing, registration, ECG, EEG, catheterization, etc. And then indirect cost, we calculated only the wage loss to the patient. So it was a majorly medical cost, a direct medical cost only, and we used the incidence-based approach. And you will notice that this is the severity. These are the comorbidities. Do you all see the cost here? So this is how the cost of illness is typically reported. So we had three categories of hospitals, and the N is the number of patients that were from which the data was extracted. So we had 257 patients from the government hospitals, 302 from semi-government, and then we had 173 from private. And the reason that this is why I explained that in some component like studies, we have used mean plus standard deviation, or you can also report, cost can also be reported using median and interquartile range. So this is the direct medical, this is the wage loss, this and this total becomes mean. Again, this is a mean. So in दोनों का total करके फिर इसका mean लेते हैं. How many patients had fees exempted, and then what is the final cost after exemption? So in this case, जो patient exempted है, because people might be having some kind of government insurance या third party वगैरह. So again, in this paper, my question is, where will you put this category? Final cost after exemption. Or do we only stop here? Total cost. Fee exempted is basically the average cost that was covered by any kind of third party. It could be government, it could be insurance, it could be under some scheme. That time Ayushman Bharat was not there because it was a dated paper. I think it was published in transaction 2019. So Ayushman Bharat उतना active नहीं था. So some of them are covered under RSBY, for example. So my question here is, ये total cost लेना चाहिए या फिर ये final cost after exemption भी? और अगर ये final cost after exemption लेना चाहिए तो कौन से category में जाएगा? Direct medical में जाएगा, non medical में जाएगा या indirect? Yes.
Sir,
Sir,
indirect.
we can take if it is a part of a review.
It was a part of review means I didn't understand.
If we are calculating this also, then we can take it out.
No, I didn't understand what you're trying to say. Take it out, or I don't know what is take it out means. We should not consider this in our systematic. Yeah, madam, you were saying something. This will be under which category? Indirect, direct.
Indirect.
Okay. Anybody else has any other comments or response? Where will you put this final cost after exemption?
I think total cost should be considered because though patient is not paying, but the system is paying for that.
Yes, I understand, but which category? Is it medical total cost? Yes. Just a minute.
It'll be
Yeah.
total
Can you all see my
direct medical.
नहीं टोटल मतलब हाँ बट टोटल क्या टोटल इधर भी है ना मैडम तो कौन सा टोटल लेना चाहिए ये टोटल लेना चाहिए या फाइनल कॉस्ट आफ्टर एग्जामिशन लेना चाहिए बिकॉज एवरीबडी इज गॉट सम एग्जामिशन राइट मीन कॉस्ट भले ही ₹7.05 है
So total cost without exemption लेना चाहिए.
ओके सो आई एम गेटिंग टू कमेंट्स कुछ लोग बोल रहे हैं टोटल कॉस्ट लेना चाहिए कुछ लोग बोल रहे हैं फॉर एग्जांपल यहाँ पे आप देखेंगे ना तो ये जो टोटल कॉस्ट है ये पूरा कॉस्ट पूरा उनको एग्जाम्पशन मिला हुआ है एवरेज के बाद it's like there is no difference after exemption that means the dengue was completely free for all the patients with this treatment there but the question is the final cost so just to tell you the difference is that you have to consider in certain cost of illness studies जहाँ पे economic burden होता है you also want to know what is the yesterday I mentioned ना ये सारे expenses जो है ये या तो हॉस्पिटल पेशेंट्स का हमने उसका लिया सो द वे दैट वी कैलकुलेटेड वर्क हमने मेडिकल रिकॉर्ड लिया गवर्नमेंट के हॉस्पिटल का जो रेट है वो हमने डाला डजंट मीन दैट द पेशेंट इज एक्चुअली पेड दिस मनी ओके दैट इज नंबर वन इन सेमी गवर्नमेंट एंड इन प्राइवेट we had to look at whether the patient had insurance or anything you'll notice that कोई भी प्राइवेट में कोई फी एग्जेम्प्ट नहीं मिला whatever they had to pay, the total was the same cost exempted here also. If you're looking at economic burden, I explained yesterday also, you have to also think what is the impact of that burden. In this case, you'll notice जो भी private hospital में गया है, उसका cost is multiple times compared to somebody who's gone to a government or a semi-government hospital, which is very important evidence because we are trying to say that for dengue patients, those who visited a government or semi-government hospital, the economic burden were considerably low. And that is why you have to consider exemption also along with the total cost. You cannot just consider total cost alone. Yesterday I mentioned ना कि आपको impact of out of pocket जो भी cost है, वो भी आपको consider करना चाहिए. So one of the ways that people get one of the things that you also get is that जो कल मैंने बताया कैटास्ट्रॉफिक हेल्थ एक्सपेंडिचर हो सकता है या उनका हार्डशिप फाइनेंसिंग हो सकता है या somebody might get poor but if you also add what is the exempted cost or some other costs were covered you also get to know what is the actual burden this is the actual burden on the community on all these patients not this one this is the total cost of provision of care this is the total cost after the benefits are there so इसको हम लोग एक दूसरे कैटेगरी में डालते हैं it's not direct medical or something we put it under a category which is we are saying that what is the total cost after exemption so if you're doing a systematic review of economic burden of dengue in India for example and this was actually picked up by David Shepard later. David Shepard is a health economics professor at Brandeis University in the US, and he's worked extensively on dengue cost of illness and cost effectiveness. So this was picked up later. So इसमें वो जो economic burden आएगा, then this is more important as evidence, not this one alone. To showcase that dengue is considerably lower in terms of cost, overall cost, compared to a private hospital. So in this case, you will not only consider the total cost, which is actually the cost of managing the disease, but you will also take into consideration this cost, which is actually the cost after exemption. So both are equally important. This will not be categorized into direct medical or non-medical because that is the first category. You will use this as another category itself by saying, you can just say data extraction में भैया कि final cost after exemption क्या होगा. And this is where you need to keep in mind based on the disease, for example, and also the context, what kind of data extraction component that we need to keep in mind. Cost effectiveness का data extraction अलग होता है. Economic burden या economic evidence का जहाँ पे if you're measuring economic burden of a disease, the data extraction is slightly different. I mean, it's not just slightly different, majorly different. So, of course, I'll cover that in the next class when we understand about data extraction and also critical tools. But these are the multiple ways in which a particular cost can be reported. So that is why you might need a health economics where ये कौन सी category में डालना चाहिए, because all papers might not report it. So that is where you might need, but if you understand the logic properly, it's not rocket science. It's just known that हाँ ये मेरे को direct medical तो चाहिए ही, total भी चाहिए, लेकिन अगर मुझे ये चीज जानना है कि how many people actually paid the, what is the actual expenses borne by the patients, then the final cost after exemption is more important, is equally important. Sorry, not more important, but equally important. So I'll just stop here. I'll give you multiple examples. Sorry. I've given you multiple examples. This is the MDR TB one. This is the glaucoma screening one. This is for urban. And then this is for dengue, which is a cost of illness. I can go on and on. There are a lot of variations. I've done like 10, 12 models for various diseases and also the patients. So, however, I just want to stop here in case what Vijay wanted. So, Vijay, you want me to go on and on? I have more examples, but I think this summarizes the differences between certain methods and the way that costs are reported.
That's fine. Or any questions, friends, you can ask. Somebody has raised a hand. Please unmute and ask question.
Sir, when you are analyzing patients from different hospitals, like from government hospitals and private hospitals, their costs will be different. So the
Yes.
number of patients you have taken from private hospitals and government hospitals are also very different. So won't it affect the final analysis?
Yeah, that is why I said that isme jab, yeah, it will, but it is more or less not that different because 173 and 257 is not that high. And people have to realize that there is something called as a power calculation within cost analysis also. So there is a sample size calculation for cost analysis. And that is what I'll explain next class. Ki, remember, you also have to keep in mind that जहाँ पे हम लोग economic burden या cost analysis का papers देखते हैं, there has to be a sample size calculation for the number of for the actual power of the sample. But at this particular time, because we saturated, like, I don't know what is the period. We looked at how many years?
Sample size calculation is
हाँ नहीं sample size नहीं हमने sample size calculate नहीं किया था because हमने जो भी patients हैं पूरे साल भर में जितने भी admit हुए सबको ले लिए थे. We did not leave out a single case. हाँ entire because हमारे पास हाँ because we had medical records of all the patients in all of these hospitals, so we did not lose out. So that is why we did not do a power calculation, but cost analysis should consider power calculation, and the calculation is slightly different when we do power calculation for cost. But I'll explain that if it comes up when we do the data extraction.
okay.
So for cost, you have to also think about what was the sample size and if there is any sample calculation done.
Okay.
Anybody else has any other question? See, cost will vary. I mean, methods will vary based on the disease. I've just given, like, for example, this is a infection. I mean, this is a dengue is a very acute stage. People get treated and they get discharged and then they're off the treatment. But if somebody is diabetic, so for example, one of the studies that I was involved very many years back, but I don't have the paper with me, I think. It was on epilepsy. So, and it was done in collaboration with St. John's. So what we did is we wanted to estimate we recruited all the patients which are newly diagnosed with epilepsy. And they were included in our study, and we followed them up for 12 months. It was a prospective study as part of a PhD student. And so all the patients who from the date of when we started the study, वहाँ पे जो भी patient reported with either reported with newly diagnosed epilepsy, those were followed up till the 12 months. So in that case, we did a power calculation because we need some sample. We can't just say 200 paper, 200 patient, 300 patient, doesn't give a logic. So we had a sample calculation based on previous years utilization of number of patients with ND, newly diagnosed epilepsy with ND reporting to St. John's Department of Neurology. So we use that as a logic for our sample calculation. So in that case, this is the way that we manage. So time period of the this is where cost may, and that I'll explain next week also during data extraction. You have to also keep in mind the incidence or the prevalence method. So if it's incidence method, it will be for 12 months. But if people have been followed, certain studies in the UK or Sweden, for example, will give you diabetes cost for 5 years, 3 years, because they have a public hospital setup. Everybody is part of the health system. So all they have to do is just get the database out and calculate the cost. So they don't have to do sample size. They don't have to go to a patient, do a prospective. They'll just take the patient database and then pull out. Number one. Number two, you also have to realize that from how the cost is being conducted. So if it's a NSSO type kind of analysis, then in that case, there is a certain bias because there is no this was taken from medical records. So it will be more robust, scientifically sound compared to somebody is reporting self-reported. So NSSO all the NSSO studies which are reporting use a self-reporting cost, which might be an overestimation or underestimation because NSSO doesn't validate the cost reported using any kind of medical records. So this is where I will, and I'll explain, I'll come back to the protocol so that you understand that there is a hierarchy of evidence of that as well. What is it self-reporting? Then it will be lower down the ladder. But what is the method to do it, to consider that? I'll explain because the neonatal systemic infections also has that. But I think I'll just stop here. We can go on and on with the cost methods, but that is not the objective. But just to answer Vijay's requirement, I try to do it. So, as I explained yesterday, that additional to the generic databases, you have to include all this cost-specific databases as well, which included EconLit, NHS EED, NHS HTA are two different. The NHS EED is not updated from 2015, but the NHS HTA is updated it goes on updating, but it has got cost effectiveness and not only the economic cost analysis. Then from the University of Tufts, there is cost effectiveness analysis registry, pediatric economic database evaluation. As I said yesterday, that this is a specific database only for pediatric. And since this was neonatal, we included that. And then in the regional databases, but also conference proceedings of H Technology Assessment International, ISPOR, IEA, JIN, and then Grey literature includes REPEC and IDEAS. These are two repositories which are used especially by economists. And then, of course, the back referencing. Search strategy, I have already explained. Data collection is straightforward. Data extraction, I'll explain next week. Risk of bias also I'll explain, but just to give you an idea that when you're looking at trial-based, there are methods like Cheers, there is a CHEC and Drummond. If you're looking at model-based, there are 3 types: Cheers statement, NICE and Phillips checklist. If you're looking at cost benefit analysis, there's a response bias called benefit cost validity. And if you're looking at cost of illness, there's another checklist called done by Larg and Moss. So I will explain this when we go to that level. So just for today, just keep that in mind. And then there is, as I mentioned, that there is a CCMG calculator where you can convert currency and the price to a common point. There is a grade, which also I'll explain after the data extraction as part of the synthesis. And then finally, you have the one more thing was left. One. Yeah. So the way that the clarity of the costing is reported, that is also important. So there is a criteria developed by two Japanese researchers by name Fukuda and Imanaka. So they have reported the way in which the cost components quantity and each of these estimates are reported. As I said, na, कि cost का जितना detailing है, that gives me a more clarity. If somebody is use self-reported, that will be not transparent. But if somebody is reported with greater detail of how the costs were captured and calculated, so there is this checklist that Fukuda and Imanaka has expressed, which you can classify into different transparency levels: high transparency, medium transparency, and low transparency. So in this case, what you're saying is, I want to also look at how the cost analysis, costing was done. Costing methodology detailing hai ki nahi? Is it does it give it clarity? What is the level of reporting? That means, does it report consultation separately, laboratory test separately, diagnostic separately? Does it report number of quantity that each of those patients used? Does it mention the unit price of those resources and the estimate of each of those cost components? So these are additional considerations that has to be done, and that is why thoda sa economic evidence when you're looking at it, and also cost effectiveness, which I'll explain. But these are all the checklists that are possible. So it becomes slightly complex. You don't have to use all, but so for example, if you're looking at economic evaluation alongside a clinical trial, Cheers checklist is good enough. Cheers stands for consolidated health economic evaluation reporting standard. That is what Cheers statement looks at. And Cheers has been updated to Cheers 2022. So there is a 2022 update to this Cheers statement. So please do not use the 2013. And I was part of the expert group which developed this checklist. But I'll explain more in detail when we come to the risk of bias. But right now, I just wanted to just make you go through this, and then I will also give you clarity on what has to be done when you're looking at pure intervention based.
So are you sharing this paper? Sorry to interrupt.
This is free. This is freely available. I've already put it in the chat box. This paper is freely available. आपको chat box में मिल जाएगा. I've already put it there.
I can't see, sir.
Chat box में नहीं.
No.
Yeah, 808 Systematic Reviews Journal Biomed Central. Got it?
Oh, no, sir. I think somewhat it's not displaying. Could you reshare, please?
Maybe you joined later, maybe that. But I think Krishna Tiwari is also shared it. So this is freely available because this is published in open source journal. However, I also wanted to share. So this is one type, जहाँ पे economic, burden or economic evidence of a disease consider होता है. I'll just let me just give you another example of how do we do cost effectiveness of an intervention. Give me 1 minute. I'll pull out a protocol from that. Can all of you see my screen?
Yes, sir.
Yeah, this is, I cannot share this paper because currently this is accepted. It should be online in the next 1 or 2 weeks. So once it's available, I can send it. I think probably by next week. Currently, proofread वाला जो version है वो मैं share कर रहा हूँ. In this case, we are not interested in the entire disease. We are interested in what is the economic evaluation of decentralized care model for managing multi-drug tuberculosis in low and middle income countries. So here I'm not looking at an economic burden of disease. I'm interested in the PICO, the entire population intervention, comparator and context. So in this case, you'll notice that you'll notice that there is an participant, which is patients involving people with studies involving people with MDR-TB, regardless of their age or gender. However, there is an intervention and there is a comparator. So when you're looking at a cost effectiveness kind of a systematic review, you're interested in the one of the intervention, either the cost saving or cost effective, then you need to use the PICO logic, intervention, comparator, outcomes, and the context. So here in this case, we have looked at the primary studies involving patients who reside in LMICs as per the World Bank criteria. जब outcomes लेते हैं, then we are saying estimated average cost per MDR-TB treated, what is the associated cost, any kind of utility scores related to health quality of life, ICER, because I'm also interested in these components apart from just the ICER. So that is where the outcomes become a little bit more, but if they are having no comparator group, we will not estimate, we will not identify that cost. So if the paper is giving me only the cost of managing or for decentralized care model for MDR-TB, I'm not interested. The paper should have decentralized care comparing with centralized care model in that paper. That is the only time I will include. If there is no comparator group, I will not include. So always remember that in a cost full economic evaluation, you always need a comparator group. You cannot do a full economic evaluation without a comparator group. So keep that in mind, please. And then, of course, there's a search strategy. So I cannot share this paper. I'm very sorry because this is not, it's accepted. It's not online. So I will, whenever it is there. And then there is in JBI method, there is a JBI dominance ranking matrix, which I'll explain as part of the synthesis whenever we reach there. And then there's a grade approach, which is separate. Do not assume that this is the same grade which is used for clinical effectiveness. There's a grade approach separately for resource utilization and costs. So that uses a different logic. It is not the same. So please keep that in mind. And then, of course, you have search strategy. And so this is what a data extraction looks like, but I'll explain more next week. Method, intervention, comparator, participant, what is the source of effectiveness data, then dates of economic data, modeling use. So I'll explain all this when we do the data extraction. And then what is the perspective and cost, and if it's converted into utility, what is the study conclusion and all that. So this I'll explain next week when we do the data extraction. But currently I just wanted to explain that these are the considerations for a intervention specific economic evaluation kind of a systematic review. I'll just stop here in case anybody has any question on this particular content. Any questions?
Sir, for the grade for economic evidence, do we have online tools like the one which we have for normal effectiveness grade? Like we can do it in Grade Pro, so it's very easy, the upgrade and downgrade thing. So do we have tools for this?
No, we don't have to do the Grade Pro because Grade Pro में अभी तक economic evidence include नहीं हुआ है. So grade you are aware of how so grade pro ka nahi hai. There is a certain way where you have the certainty of evidence. In case you want to know, I'll just show you how is it reported. This is again available free because this is Cochrane library, so Cochrane CSR भी है freely available है. But I'll just show you. You have asked the question. Use a different format. Grade Pro is not used for there. The Cochrane handbook जो कल मैंने chapter 20 भेजा है, इसमें सारा link है. You can look at that.
अच्छा, okay, sir.
तो उसमें वो reference paper भी है. It's got a reference paper, and as I said that maybe in a month or two the JBI guideline will also come. जहाँ पे हम लोग ने grade कहाँ पर करना है, is it compulsory or not? So mandatory है या So the logic is the same. You downgrade or upgrade, but grade Pro is not. It's a table that we have to use. So this paper gives you an idea. I'm trying to find out कहाँ पे है. I put it in the chat box because people are. But the chapter 20 will give you a background on how to do the grade for economic evidence. So in case you're doing a clinical effectiveness and cost effectiveness systematic review, and you have grade being done for clinical effectiveness, then you have to also consider the grade for the cost effectiveness as well. If there are cost effectiveness studies, there are no cost effectiveness studies, कुछ करने की जरूरत. I'm not given the table number. You have to manually search for that. Anybody else has any other question meanwhile? But it is very straightforward. You downgrade, upgrade. But I'll explain grade ka when we read the synthesis stage. I'll explain. Don't worry. Anyway, I've noted it down. This paper gives you the background. Chapter 20 has the description of the reference paper. So any questions? It's not very easy to do, but it is not rocket science either. You need to have some understanding of economic evidence, without which economic evidence for systematic review is not possible. And that is another reason that not too many reviews are focusing on economic evidence. That is another. So you don't need a grade pro. But please understand that these are Cochrane reviews, so Cochrane review में the grades are directly accessible. You don't have to pay any money for access to grade pro. Any other question? Any of you interested to embark on a economic evidence systematic review? Okay, Priyanka and Nikita. Do you have any topic in mind? People who have raised their hands, do you have any topic in mind?
Sir, day in, day out, I'll be seeing a lot of mental illness patients, sir. And one of their major burden is the travel expenditure to tertiary center from villages. So we can do exclusively the cost analysis, keeping aside the drug costs, the travel economic impact on the patients. One of the reasons.
No, you cannot. You cannot focus exclusively on that because you are doing a systematic review. Remember, so you cannot isolate only that I'm interested in. However, if you're doing a methodological review, and I do not know whether you people are familiar, there's something called as a methodological review where you're trying to understand which are the ways in which people have estimated. For example, mental illness, more than the indirect, it is also more important to identify productivity losses or indirect costs. So methodological reviews are where you take a review, you do a systematic review, you identify the studies, but you do not go into the PICO, you're not interested in economic burden or something, you're interested in how the method of economic evidence was captured. And you might focus only on productivity loss. I think what's more important in mental illness, if you're looking at mental illness specifically, for example, are you looking at schizophrenia, those kind of conditions, right? Not anxiety, depression. Or you're including that as well?
So schizophrenia mainly, sir. One of the reasons schizophrenia fails treatment is cost of treatment. Drugs are not costly, sir, but travel and those things are costly, sir.
Yeah, I don't think a systematic review can focus only on that. You can, it would be rather important to identify the economic evidence around schizophrenia and low and middle income country, for example, and then highlight that the evidence points towards travel cost or repeated visits as being one of the factors for people not to utilize continuous care, or people are dropping out. But try not to be very selective of what cost are you including. But indirect costs you can say. For example, in mental illness, but also TB, a lot of indirect costs are not being done. People are just using travel or probably direct costs. People are not calculating enough or at least analyzing and reporting enough productivity losses, especially around, for example, schizophrenia hoga to caregiver ka jo productivity loss hai to manage that patient. That is very important to capture. I don't think there's evidence around that so much. And if there is no evidence, that shows that future researchers should focus on that also. So I don't try to cherry pick any category of cost. However, if the disease warrants Alzheimer's, Parkinson's, neurological diseases, schizophrenia, which is mental, TB, for example, which requires a lot of caregiver support for the patient to receive care, also has an indirect cost component. So I don't cherry pick a cost. That's my suggestion. Now, if you want to do only the methodological aspects and say, oh, I'm not interested in the cost reporting, I'm interested how the costs were calculated, then in that case, you're doing a methodological type of review. You're not interested only in reporting the economic burden of the cost effective. So don't cherry pick the cost. That is what I would say. You can report economic evidence and show that based on the evidence that travel cost of travel or cost of repeated visit is a criteria for people to drop out of care, or actually the compliance to treatment is affected due to travel. And this was found even for example, glaucoma. I did a study on compliance for glaucoma treatment, and we found not the travel cost or the cost of medication. Actually, people forget that they have to purchase or use glaucoma medication. So cost was not a factor. So when you look at utilization, you might have other factors beyond travel, but other patient level or caregiver characteristics which might influence the utilization. Anybody else has any other disease or intervention in mind?
Hello, sir.
Yes.
I just want to ask you that whether I can go for that socio-economic burden of cognitive deficits among children.
Socio-economic burden of
deficit among children.
Madam, your voice is not properly, I mean, it's audible, but I cannot make out any words. If anybody else can, hearing it properly, probably. I can understand socio-economic burden, but not the disease or the disease condition.
Like cognitive impairment or intellectual
Madam Kulumina,
yes,
you are audible, but I cannot comprehend the word. There is some bad internet connectivity at your end. So you can put it in the chat box and I'll try to respond.
Okay.
Yeah, meanwhile, anybody else has any other protocol or a question in mind where you need some input at this point?
So costs related to thalassemia care and like they require frequent transfusions. So can it be done?
Cost related to thalassemia treatment or thalassemia like it. So here that is what I'm saying, that if you're looking at economic burden of, so are you interested in thalassemia, economic burden of thalassemia patients, right?
Yeah.
Yeah, so in that case, as I said, that you might have to consider all types of cost: direct medical, direct non-medical, indirect, any kind of exemption that people are getting. How much is the total cost minus that exemption? What are the factors that influence compliance, because thalassemia requires multiple visits. So those are other factors that you can keep in mind. So don't pick up a particular category. For example, don't use the word cost in the title. You can use cost if you're looking at a specific intervention. For example, I want to understand the cost of telemedicine for managing diabetic retinopathy. Then it's fine. But typically, if you want to look at a disease, then use the economic burden as the title of the systematic.
Okay.
Madam Kulumina is mentioning, evaluate the societal economic burden of cognitive deficits among children. Again, this is an issue that economic burden of cognitive deficits among children is more suitable. So when you use the word societal, then you are only taking those studies which have got indirect costs reported. That is what is called as society. So I'll explain perspective again when we look at the data extraction. So there are multiple perspectives when you look at economic evaluation or economic evidence. When you're looking at purely from a hospital cost, direct cost, that's a hospital perspective. When you're including it from a patient, which includes travel also, that is called a patient perspective. When you're looking at reimbursement as well, then or insurance is reimbursed that amount, that is called third party. When you're looking at indirect costs, that is called societal perspective. So the moment you use the word societal, you're excluding all the studies which have only reported direct medical and direct non-medical. So, Madam Kulumina, the title should be Economic Burden of Cognitive Deficits Among Children. Now, do you want to look at LMIC? Do you want to look at India? Do you want to look at South Asia? So that context will also come into picture.
So it's a more.
Madam, I
So, yeah,
cannot
nice,
hear
yeah.
you. Madam, I cannot hear you. I cannot understand. So you can put it in the chat box. There's some connectivity issue, or maybe your mic is not working properly. So I can hear you, but I cannot comprehend the words that is. Anybody else has any other topic or question that you have in mind?
Sir, I was
Hello, sir. Hello, sir. Can you hear me, sir?
Yeah. Yeah, I can hear you.
Okay, thank you. Thank you,
Daniel.
sir. I have this in mind, the prevalence of malaria, morbidity, and mortality among children under 5 in Africa.
But this is, Daniel, this will be a prevalence. So how is it related to economic evidence? Well, prevalence will not come into the economic part, right? It's an epidemiological word.
Yes, during your explanation concerning the method of economic evaluation, you talked about the partial economic evaluation and the full economic evaluation, and you under the partial, you said the prevalence can be looked at when you want to compare for.
So that is not prevalence for epidemiology. That is a prevalence method for cost of illness. It's a cost of illness type of. It's a cost of illness are done by two methods: incidence method and prevalence method. So don't confuse that with the epidemiological prevalence of incidence.
Okay.
So if you're interested in the economic burden, you can look at prevalence and economic burden of that disease in Africa. That's acceptable.
Okay. Okay, sir.
hello, sir.
Yeah.
So I had an idea in my mind, like comparing Ayushman Bharat out-of-pocket expenditure, those who are availing Ayushman Bharat policy Yojana, to compare out-of-pocket expenditure in government setup and private facility.
Right. So you're not interested. So you're basically saying that I'm interested on the effectiveness of Ayushman Bharat scheme. So and you're looking at purely solely on the out-of-pocket expenditure difference between Ayushman Bharat scheme in government and private, but you're not interested in non-insured. Like somebody is not insured, you're not interested in that.
Sir, if a person is non-insured, there'll be a very huge difference between the private and government setup.
Okay, so here what you're saying is here is the thing. You're not looking at economic burden. Number one, you're not looking at cost effectiveness type of systematic review. So number two, what you are saying is within the economic burden of the all the diseases that are covered, I'm interested only in one component of the reimbursement, specifically under this particular scheme, because I want to understand the total cost incurred for somebody going into an Ayushman Bharat scheme in a government hospital and the other one is going into a private hospital. Am I understanding correctly?
Yes, sir.
Yeah. So this will be a subcategory within the economic evidence component, which is called as an expenditure kind of analysis. So you're trying to understand just the expenditure. You're not interested in anything else. You want to understand only the expenditure analysis between these components. The challenge that you might have is some studies might not report both kind of patients. They might report only Ayushman Bharat patients. So in that case, you need to keep in mind that this is actually coming under economic evidence only. But you're not specific to any disease or any kind of specific to treatment. So you're interested more only on the expenditure, expenditures. So the title that would be possibly like this is that expenditures among Ayushman Bharat scheme patients in government and public hospitals, government and private hospitals in India, a systematic review. So that could be possible. It's called an expenditure analysis. So you're not interested on what the cost is incurred, what is the cost of treatment, those kind of things might be of interest, but you're more interested on the total cost after exemption. After Ayushman Bharat scheme के बाद जो बाकी जो पैसा बचता है उसका कितना extent है public or private में? I'm assuming that is where you're interested, right?
No, exactly. It is like in Ayushman Bharat, they'll provide the packages. Whether it is in the government setup or it is in the private setup, that package cost is bear by the government. That is the scheme who is paying for that package. But other than those, the other costs like travel cost, if any investigation has to be done, if things are not provided in Ayushman Bharat scheme, like few instruments or equipments which is required. If that has to be
I
incurred.
doubt whether, my suggestion is, madam, don't go in that path. If you want to look at the impact of Ayushman Bharat scheme and then you want to look at that as a systematic review, if you only go into these components, that might not be a proper way of looking at it. So you might want to say, I want to look at the impact of Ayushman Bharat scheme in terms of. So what I understand is that there is a standard package available, yes, but are people incurring more cost in terms of travel or indirect cost reported? It will be a so narrow review. Yes, fine, good. It is a very narrow systematic review. If you feel that that is important evidence to share as part of evidence for policy making, go for it. I have not done that level of narrow kind of review. I usually go a little broad.
Okay, sir. Okay, so could you suggest what changes should I make?
First of all, did you check I think there is a recent. I think there is a group that just did a analysis, but it was not a systematic review. They tried to give a history of all the national insurance schemes that are being conducted in the government, and I think so. Did you see any systematic review which is measuring the impact of Ayushman Bharat scheme, like in terms of reduction in out-of-pocket expenditure?
I have to see too.
Yeah, so probably that would be the first step that I suggest. See if there's a systematic review already. If yes, then have they looked into this parameter as any of those outcomes? If no, then there is opportunity. If there is no systematic review, then you have an opportunity. If there is one and they've not looked into it, then you can say that I'm only interested in the direct non-medical and the indirect. I'm not interested in the direct medical cost. And that is also good enough.
Okay, so
that's what I assume, right? You're not interested in direct medical. You're saying that I want to know whether direct non-medical, like travel, caregiver, travel for that food of caregiver, for example, or indirect in terms of productivity loss, was it higher? So, for example, somebody who's traveling further will incur more productivity loss in terms of number of days of travel or, those kind of factors. So, I'm assuming you're only interested in the direct non-medical and the indirect. You're not interested in direct medical. So at this particular, if you're saying it's including, then it is basically impact of Ayushman Bharat on out-of-pocket expenditure. That's it. So in that case, you'll include all the three. It's not just looking at travel, and it will be part of the analysis based on how the studies are reporting. Yes. In that case, then you look at all the three, no problem.
Okay, sir.
So the way that I would look at is impact of Ayushman Bharat on out-of-pocket expenditure between in public beneficiaries from government hospitals and private hospitals. That would be the title of this.
Okay, sir. Thank you, sir.
Yeah, Priyanka, you had a question. You have raised your hand.
Sir, can you hear me, sir, now?
Oh,
Hello,
yeah, I
sir.
can hear you. Yeah, I can hear you.
Sir, you're talking about the context, sir. So could you advise me which one will be better, like India or South Asia or LMIT, if I'm going for evaluating the economic burden of cognitive deficits among the children, sir?
Yes. So, see, the context is important in terms of, so we'll have to understand why we look at global evidence as part of JBI, Cochrane, or Campbell. The main reason that we look at global or regional is to do comparative analysis. If you're interested to compare what is the economic burden of cognitive defects among children in India versus, say, Bangladesh or, say, Mexico, for example, then you will have to go for LMIC. If you're not interested to do a comparison between countries, then the only way you can do it is within the India. So you're not saying, I'm not interested to know between countries. I'm interested within India, within regions, north, south, east, west, rural, urban, male children, female children, those kind of things. So the whole thing is that I always tell people that the way that you decide a context is global is always suitable, no doubt on that. But in some cases, global might not be suitable because some of the diseases some of the diseases are quite specific to LMIC context. For example, if you take glaucoma, for example, angle closure glaucoma is more prevalent in developing countries compared to developed countries. And you'll notice most of the reviews of glaucoma is happening on open angle closure glaucoma because most of the reviews are being done by the developed countries.
Yes, sir.
So we are currently, so that is where one context that, okay, this disease is more specific to developing countries, so hence I'm interested in that. That is one way to look at it. The other way to look at it is, for example, if there is a specific region which has got a very high burden. So if you look at micronutrient deficiencies, South Asia will have very high micronutrient deficiencies compared to other regions, even within Asia or probably other LMICs also. India and Bangladesh and Nepal contribute a very large number of micronutrient deficiencies in pregnant and lactating women of reproductive age. So this is where you have to think about various considerations before you say, okay, should I go global? Should I go, LMICs? Now, for example, in our context, which I just explained, we were not interested in decentralized care in all countries as an economic evaluation because decentralized care is not used in, one is MDR-TB is not a disease that most of the high-income countries have. So there is no point there. And the other one is decentralized care is more suitable as an intervention for resource, low resource situations. So this is why we use only LMIs. So if you want to do comparison, then you have to consider multiple countries. The decision whether you want to look at South Asia, Southeast Asia, Asia Pacific, somebody came from Africa. So if you are specific only for Sub-Saharan Africa, for example, then you are looking at, there's a certain reason that you have to justify why you are, focusing on that as part of your review. But if you want to get your protocol published in Campbell, JBI, or Cochrane kind of a thing, they will not accept, India or South Asia. They will only probably accept only LMIC or global. Cochrane, in fact, doesn't even accept Sub-Saharan Africa. They will only accept LMIC or global. So that is there. So Mohammed is asking if, Mohammed is asking if the disease is more common to a specific geography. Is there any downside to do a global review instead of pre-specifying the region? Mohammed, I did not understand. What are you trying to ask him?
Sir, I mean, yes, sir. I mean, even if a disease is more common in a place, like, do we need to do a regional review or we can just do a global review? We will get more studies from that region. But Do we need to
See,
restrict?
you have to, yeah. See, there are multiple things that have to be thought when you are deciding, and this is not just general for economic evidence, that's a general across all systematic review types. The way that I do, and the way that if I would have been teaching systematic review, and when I do my workshop, the way I explain them is, if you first look whether the disease is prevalent globally, then it makes sense to look at global. Number one. Number two, the second is if the disease is more common in a particular region, it makes more sense to go there. But if you're aiming, now I don't do typically non-JBI, non-Cochrane, non-Campbell. It's very rarely that I end up doing any of these. So my reviews are typically, either LMIC or global. Recently, I've started to focus on South Asia. The only reason is because I'm doing one on micronutrient deficiencies. I'm doing one on NCDs among indigenous populations, where I'm not interested globally across everywhere. So the second point that you need to consider is, okay, I want to do a comparative analysis, but do I have the resources and the time to focus? Because if you're looking at global or if you're looking at LMICs, then that kind of team members because a lot of time will go into data extraction and things like that. One of the reviews that we're looking at only on economic evaluation of NCDs in South Asian region, we found 405 studies in our inclusion. Now, it is not easy to have a team and do data extraction of 405 studies. And we had to include all the WHO SCRO region. So we have to include Timor-Leste because that is part of WHO. So sometimes funding restricts your region. If it's not funded, then keep in mind that resources and time is also a consideration, and not just the disease burden or severity, which is very specific to a particular region. So try to be little realistic and practical when you're doing it, rather than just using it from a methodological point of view. If you're aiming for a Campbell or a JBI review, unfortunately, neither the protocol nor the full review will accept anything less than an LMIC. And I've tried it in the past. I actually discussed with the editor-in-chief and I said, I come from India. If I'm looking at epidemiology, humanistic and economic burden, all the three outcomes of a particular disease, the policy maker is not interested in what's happening in Nepal, for example. But they did not accept. They said, no, we want to retain our global and regional. But if you're publishing in any other journal, which is non-JBI, non-Campbell, non-Cochrane, well, those journals accept that. So I'm on the editorial board of Systematic Reviews, which is a journal specific to systematic reviews, and the associate editor there. In systematic reviews, we accept any type. I mean, the protocol that I just shared on neonatal systemic infection only focus on South Asia. Now, we did it because India is part of South Asia. We wanted to do a comparative analysis, but we did not have a huge team to go to a LMIC. So we said, no, we are not interested. So there is no single answer to your question. Mohammed, Akib, are you getting some clarity? Because there is no single way to think of when should you look at LMIC or something.
Yes, sir. It is clearer now.
For example, for the dog-mediated rabies, which if you see my screen here, this had only India. We did not look at anything else. In fact, one of the reviews that is currently ongoing for snake bites, we are not interested on any other country except India, because India is the biggest, largest, very high burden of snake bites in the world. So we are not interested beyond this. And that will be accepted even in a Lancet Regional Health, for example. They won't question why you're not looking at LMIC or South Asia, because snake bites are major in India. But I cannot compare. I cannot compare where does economic burden of snake bites or this rabies for India stand against any other country. And that if you are interested to do a comparative analysis across countries, then look at LMICs or South Asia. I wouldn't suggest a country specific. Anybody else has any question or any other topics that they want to comment right now? Otherwise, I think we have already reached 10 o'clock, so we can stop.